in the hotel room.
Welcome everyone to our Department of Psychiatry Grand Rounds. We're honored to have with us today David Luxton, Dr. David Luxton. Dr. Luxton is a research psychologist and program manager at the National Center for Telehealth and Technology, Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury, and he's affiliate assistant professor of psychiatry and behavioral sciences at the University of Washington School of Medicine. Dr. Luxton received his PhD in clinical psychology from the University of Kansas. He's published papers and technical reports in the field of military psychological health, telehealth, and suicidology, including the Department of Defense Suicide Event Report for 2008 and 2009. He's a principal investigator on two major grant-funded research efforts. The first is a suicide prevention outreach program for military personnel, and the second is a randomized control trial of an in-home, web-based behavioral activation treatment for soldiers and veterans with depression. He's also co-investigator on three other grant-funded projects, including a large epidemiological study that will determine suicide rates among all U.S. service members who have served in Operation Enduring Freedom and Operation Iraqi Freedom. Dr. Luxton is a licensed clinical psychologist in Washington State and is a veteran of the United States Air Force. He is also an experienced musician, producer, and film composer, and he's released several albums on Wayfarer Records, an independent record label he founded in Olympia, Washington. And are those available on iTunes?
Yes,
or Amazon? Okay. Go, Dr. Luxton.
Thanks for coming today. The title of my talk is Carrying Letters, a Suicide Prevention Strategy. As I go through this, I've left some time at the end for questions. If you have a burning question you want to ask during the talk, that's okay. And if I'm not speaking loud enough in the back there, just let me know. Hopefully this microphone's working okay. So first thing, I'm going to tell you a little bit about the National Center for Telehealth and Technology, a little bit about what it is that we do. And then I'm going to provide some background on the carrying letters concept. I'll talk about some of the preliminary studies in the area. And then I'll talk a little bit about the theory of why this intervention might reduce suicide rates. And I'll talk about some of the strengths of the carrying letters concept for use in hospitals. And I'll talk about a pilot carrying letters project that we just wrapped up at Madigan Army Medical Center. And then I'll talk about a grant-funded multi-site randomized controlled trial that we're about to launch. The National Center for Telehealth Technology, or T2, is a component center of the Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury. We were established in late 2007 at Joint Base Lewis-McChord. And after our first year, we had about 43 employees. We are now about double that, and we continue to grow. And our mission is to lead the development of telehealth and technology solutions for psychological health and traumatic brain injury to improve the lives of our nation's warriors, veterans, and their families. Our headquarters and primary operations are based at Joint Base Lewis-McChord. We also have a satellite office on the East Coast in Washington, D.C. And we have a number of employees embedded in other federal organizations to include the Armed Forces Health Surveillance Center in Washington, D.C., and also the National Center for PTSD down in Palo Alto. One of our core missions in T2 is suicide surveillance for the Department of Defense. And we are also developing and studying prevention programs. And the Carrying Letters program is one such program. But before I start describing the program, I want to show this slide here to demonstrate the seriousness of the suicide problem in the military. And I'm sure you have seen this in the media in recent years. It continues to be a problem. And if you'll notice here, I'm showing between 2001 and 2008, and you'll notice an upward trend. And I can tell you in 2009 and 2010, the trend does continue. And what's really alarming about this is that historically, the suicide rates among military service personnel is much lower than that of the civilian population. And it's typically attributed to the fact that people are screened when they enter the military. So you've got a higher functioning population, and they also have plenty of services available to them. And in recent years, it has come up to the point of, or around the point of that of the civilian population. So obviously it's caused a lot of attention for senior leadership, or gotten their attention, and as well as society as a whole. And so in recognizing this problem, T2 has investigated types of interventions that might help to reduce suicide among service members, and one of which is the Caring Letters program. And this is basically what it is. Caring Letters is the mailing of brief caring letters and reminders of available treatment to high risk for suicide patients after they leave inpatient psychiatry treatment. And the concept was originally developed and evaluated by Jerome Motto in the 1970s. And what he and his research team did is they met with 3,005 inpatients at inpatient units in the San Francisco area. I think there was about 9 hospitals. And they conducted a psychosocial interview with patients. And then after they were discharged, they waited 30 days, and then they contacted the patients to see whether or not they had continued in some sort of after treatment. And the patients who did not continue after treatment, they randomly divided into 2 subgroups. And in one of the groups, they sent brief caring letters to them at regular intervals for 5 years. And in the other group, which served as a control group, they did not send any follow-up contacts. So there were basically 3 groups. There was a group that continued in care, who did not receive any follow-up contact, and then there were the 2 subgroups that did not continue in care, one that would receive these caring letters and one that did not. Here's an example of one of Motto's letters. Dear patient name, it has been some time since you were here at the hospital, and we hope that things are going well for you. If you wish to drop us a note, we would be glad to hear from you. So some of the key points about Motto's letters is that they were very brief. They were just brief expressions of care. And they were non-demanding. They didn't ask anything of the patient. They weren't asking them to provide data. Motto also customized his letters slightly as well. For example, if a patient had written back to them, they might include some of that contact in the next letters. So they would vary every time that they would send a letter. So these are the findings from Motto's original work. Patients in the contact group had a lower suicide rate in all 5 years of the study. Survival analysis revealed a significantly lower rate in the contact group for the first 2 years. So in the first 2 years, there was a significant difference between the group that received the letters and the group that did not in their suicide rates. And we're talking about mortalities. And they did a follow-up 15 years later, and what they found is that over time, after they stopped sending the letters, the rates went back up to the same between the groups. And so on this graph right here, you'll notice the bottom trend line there. That is the contact group, which had the lowest number of suicides. The middle line is the no contact group that they served as a control group. And then the top line is the contact group. And you might be wondering, well, why is it that the treatment group. You might be wondering, why has the treatment group have the highest suicide mortalities? And I don't really know, but my guess is that they're just a somewhat different clinical population. Maybe they have more severe diagnoses, or there's other characteristics that were different about them. So the Caring Letters program appears to exert a significant preventive influence for at least 2 years. And it may possibly be due to the higher frequency of letters in the first couple of years. So in Motto's study, they sent them, I think it was every month, and then it went down to every couple months, and then down to every 4 months. And then, so it was that first 2 years that they saw the effect. That's when they were sending the most letters. So it might be just the number of letters and that frequency of contact that makes a difference. And it's also that time right after discharge from inpatient treatment that patients are at very high risk for suicide. In fact, I've read some studies that suggest that the risk for patients to suicide after inpatient treatment is about 100 times more than people who have not been treated for psychiatric conditions in inpatient units. So it's clear that the first few weeks and months after treatment, they're very high risk. And the other thing about Motto's study is that it showed a long-term preventative trend. So within that 5 years, and then somewhat beyond that, the rates of suicide was much lower in those that had received the caring contact. And there's been a couple other similar randomized controlled trial studies that have shown success in this type of intervention. Carter and others reported in 2007 a study in Australia where they sent non-personalized caring postcards to previous suicide attempters. And these were people who were hospitalized for self-poisoning. And they sent the postcards for 2 years. And the results indicated that those who had received the cards had fewer self-inflicted injuries in later inpatient hospital days compared to controls. Now, in Carter's study, they didn't have enough participants to be powered adequately to look at mortality rates. Nonetheless, it does show that receiving these caring contacts did have some sort of preventive effect on self-harm behaviors. Fleischman and others reported in 2008 a study by the World Health Organization that was conducted in 5 nations. And what they did is they did psychoeducation and a series of personalized follow-up contacts, either by telephone or in-person visits, and to a randomly selected group of suicide attempters. And what they found is that those who had received the contact had significantly fewer deaths by suicide compared to the control group. So taken together, Motto's original study is the first and the only published study that I'm aware of that has shown a reduction in suicide mortalities in an empirically supported type of treatment, or in a treatment that provides empirical support for this type of intervention. The other studies also support the intervention. So what is it about these caring letters that might actually reduce suicide? Well, one leading theory at this time is Thomas Joiner's theory of interpersonal psychological theory of suicide. And basically what the theory attempts to do is to explain what makes people suicide. And he describes 3 components to the theory. One is a capacity to enact lethal self-injury. A person must have this to actually do it. Perceived burdensomeness, and also failed belongingness. So it's possible that caring letters might contribute to a sense of belongingness. They help to maintain a connection between a person who is high risk and someone out there who cares about them. And so it might promote a sense of belonging and be particularly effective for those people who isolate after treatment. It's also possible that the letters themselves, they act as a route to treatment. So if you're receiving the letters and if you're in crisis, it serves as a reminder that there's treatment out there and there is someone out there who's willing to listen to me. And so Motto reported a number of cases in their study where patients sent letters back and they were able to reconnect those patients to continued treatment. And another aspect too is that in our program, which I'll talk about here in a minute, we also included hotlines and other referral information in our letters. So it serves like they can keep this on hand, so if patients are in crisis, they can use those resources. And the letters are also reaching people in a time that patients are at high risk. As I was mentioning earlier, right after discharge is a time of high risk for suicide. So they're receiving these contacts during this time, which might be effective. So some of the strengths of caring letters for use in hospitals and potentially other settings is that this is one of the only empirically supported treatments, psychological interventions, that has been shown to reduce suicide mortalities in a randomized clinical trial. It's also a very simple and inexpensive intervention to reduce suicide. It reaches high-risk patients that do not continue in care. And it also offers a long-term suicide risk reduction effect. Again, in Motto's study, they saw this trend for 5 years and maybe somewhat more. And so it suggests that there's an effect for much greater than just right after discharge. And you can also use existing staff and resources to implement this program. So one of T2's core missions is suicide surveillance for the Department of Defense, and also developing and evaluating prevention programs. So we decided to pilot the caring letters concept at Madigan Army Medical Center to, one, evaluate the feasibility of doing it in a military setting. Would it work as far as doing the actual protocol? And then we wanted to explore trends towards reduction of psychiatric rehospitalizations. We knew we wouldn't have a large enough sample to be powered adequately to look at actual mortalities in a pilot study. We also wanted to assess preference for and feasibility of email correspondence. Motto sent letters, Carter sent postcards. We want to do a technology-based intervention, emails. So we wanted to see, would this even work? And we also wanted to identify best practices and gather data to inform a randomized controlled study. So we did a number of steps in preparing our protocol. First off, we consulted with a number of subject matter experts to include Drs. Jerome Motto and also Marshall Linehan here at the University of Washington. We also conducted a focus group with soldiers regarding the concept and methodology. And one of the primary reasons for doing that is we wanted to assess whether or not they thought that receiving caring contacts via email would be feasible. How often do they check their email, and does this idea really make any sense? And the neat thing about email is that all service members, all active duty service members, have email accounts, and they check them often. And so majority of the soldiers said yes, email is probably the way to go. And we also spent a lot of time thinking about safety contingency plans, doing safety planning for the study. And for example, like what if a patient sends a crisis email or a letter back to us? What would be our procedures? So we consulted with the inpatient unit at Madigan to make sure that we were coordinating with them and developing a plan in those types of scenarios, what we would do. And also we consulted with our institutional review board at Madigan as well. So this is the basic methodology of our pilot protocol. Our research assistant first would consult with the treatment team to identify eligible patients. So basically, her name is Jen, and she's actually here today. Not to embarrass you, Jen. So I'm going to refer to her in the third person. Hopefully she won't mind. She would attend the morning meetings with the inpatient staff, and they would talk about new patients coming in. And then afterwards, she would consult with the treatment team and make sure that it'd be okay to approach the patient to enroll in the study. And so exclusion criteria really, if the treatment team didn't feel that the patient was competent to consent, obviously we wouldn't enroll them. And so Jen would then make an appointment with the patient to meet with them, and then she would explain the study procedures, consent the patient, and then she would conduct an interview with the patient. And our interviews were about an hour long, and in those interviews we included a measure of basic demographic information, some military history, social functioning. We also did some stuff assessing positive assets. So if we wanted to learn a bit about the patient's functioning, and if there were some positive things in there, like hobbies and so forth, we would include that information in our letters to them, like hoping that they're enjoying those things and so forth. And we also included a measure of depression, the PHQ-9, and we included the Rudd Suicide Ideation Scale to assess suicide ideation, and we also included the Reasons for Living Scale as well. So then after the interview, Jen would, she'd be up on the unit enrolling other patients and things. She would check in with the patient if they were around, just say hello, and therefore maintaining a positive connection with the patient while they were staying on the unit. And then after the patient was discharged, we would begin sending caring letters at a certain interval. And this interval follows that of Motto. However, we did add one additional letter. Motto sent 12 in the first 24 months. We sent 13. And the reason why is that we wanted to send one shortly after discharge rather than waiting a month. So we added one letter. So we send 2 in the first month, and then we send, after that we send 3 letters for the next 3 months, and then we send 4 bi-monthly, and then for the last part of the year, last part of the second year, we send every 3rd month. So a total of 13 letters. One thing that we made sure that we did was keep the content of the written letters the same as the emails. So we used a template that we customized for every patient. And again, we used information that we got from the interview with the patient to include in the letters to make them customized and personalized for each patient. And we determined whether or not we would send it via regular mail or emails based on the preferences of the patient. So we asked the patient what would they prefer. And we also got, as for backup contact information, we got both their mailing and email addresses. If they had an alternate email, we would get that as well, just in case the primary one didn't work. And we also signed each letter or email by two people. So Jen would sign it, and we would have the head nurse sign it as well. And the reason for that is to maintain continuity in case one of them left. So we would have at least one person that the patient met and knew while they were on the unit sending the letters. And we also included referral information at the end of each letter, and I'll show you that here in a second. So here's one of our sample caring emails. Dear participant, and of course their name, we appreciated the opportunity to get to know you while you were here at Madigan Army Medical Center. We hope things are going well for you. We remember how you said you like hiking around the South Puget Sound. With the return of the summer weather, we hope that you're getting a chance to get out there and explore some new trails. Anyway, we just wanted to send you a quick email to let you know that we are thinking about you and wishing you well. If you wish to drop us a note, we would be glad to hear from you. Sincerely, Sarah and Laura, or Jen and Laura. And this is an example of, or this is what we included in our letters for our pilot program. And you'll notice that we included a suicide prevention hotline, but we also included hotlines to a number of different types of services. And we did that for a couple of reasons. One, I think it's just a good idea to do that in case they need those services. But also, we didn't want to make the letters just about suicide. We wanted to keep it sort of general for anything that they might need. And these are the results from our pilot study, which we just wrapped up. We enrolled a total of 110 patients, 20 women and 90 men. Mean age was 29 years old, and about 60% had documented suicidal ideation or self-harm planning at admission to the unit. About 25% had attempted suicide immediately before admission to the unit. And the primary diagnosis for participants was depressive disorder, about half. And I will say about these numbers, we gathered this information, one, to see how much our sample would look like what Motto had, which it is very similar. And also, in the future, we'll want to collect this information to maybe to create some subgroups to compare. You know, our patients who have a number of previous suicide attempts, are the letters more effective for them versus people who don't, and so forth. So we wanted to pilot gathering this information. The average length of stay on the unit was 6 days, and that ranged from 1 to 20 days. So we have sent 436 letters to date, and emails as well. And the participants indicated about 3/4 of them preferred email over postal mail. So we sent 72% of what we sent were emails. 15 participants were readmitted for treatment to the unit compared to 20 patients in usual care. So there were less people readmitted who had been receiving our letters. Stuff to really make any decisions about what that really means. It is limited in that we didn't have a control group in our pilot study, so we sent letters through everyone who we enrolled, and so there might be something different about the patients who are not enrolled. They may have not been on the unit as long as other ones. We didn't have a chance to meet with them or something, but nonetheless does suggest that the letters may have some kind of preventive effect on readmittance rates, similar to that found by Carter. 20 participants sent responses back to us, all of which were positive statements about the program. In other words, they would say things like, "Thank you for thinking of me. It's nice to know that someone out there is thinking of me and asking about me." We did have one email that was returned undeliverable. We did set up a receipt feature on the emails so that if they weren't receiving it, we might get an indication of that, and then we would revert to either an alternate email or we could revert to using regular mail for them. one limitation is that we don't know if all the emails are received or not. If they have a spam feature, we may have missed them, but there's no way of knowing otherwise. And we did not have any adverse events that required us to implement our safety procedures during the pilot program. We did have, I think it was 3 or so patients write back to us, and our protocol calls for us to read everything that comes back to us and assess, is there some risk here? None of them had any indication of intent for self-harm or harm to others, but a couple of them did have some indication of distress. So we followed our IRB-approved protocol and notified the inpatient unit that we would receive these letters, and they would take it from there. So the results of our pilot study suggest that, well, this program is feasible for use at a military treatment facility. We were able to get up there, meet with patients, send emails and letters, and it was at least effective as a protocol. But we know that we need to do a randomized controlled trial, a big study, to determine whether or not this intervention has any effect on suicide mortalities. And there has not been a replication of Motto's original work. So we wrote and have been awarded a grant awarded by the Military Operational Medicine Research Program to conduct a very large randomized controlled trial. And what the trial will do is compare the caring letters intervention to usual care to prevent suicide among service members and veterans. So basically, this is the mortality piece. We are going to send caring emails, and we're going to look at death rates between the group that receives the letters and those that don't, and compare them. And we're also going to examine hospitalization rates for suicide behaviors and also time to a suicide behavior requiring hospitalization. So what we predict is that patients who receive the letters, there'll be a longer time between discharge from the unit, the index admission to the unit, to a suicide event in the group that receives the letters. And we are also going to update the methodology by using email instead of regular mail. It's going to be a 5-year study, and we are going to enroll approximately 4,730 patients, and this is based on a power analysis that we did. And we're going to enroll patients from 6 major Department of Defense military treatment facilities. It is a multinational study. We have one site that's in Germany, and I'm hoping we can pick one up in Australia as well. And we'll also be recruiting from 2 VA medical centers. And we're going to randomize patients into either a caring letters email condition or a usual care no email condition. And we're going to send the contact group or the caring letters group letters at a set schedule, just as we did in the pilot study. And we're going to do it for 2 years. We're not going to do the full 5 years that Motto did. We're just going to do it for 2 years. And then we will use the National Death Index to track patient mortality. So at the end of 2 years, we're going to look at mortality rates for both groups and compare them. We'll also look at subgroups as well. There'll be a group that will continue in care, and there will be a group that will not continue in care. And so we'll look at those subgroups. We'll be able to look at medical records as well. For patients who stay in the military, we'll be able to track those treatment records. Patients in the VA as well, we'll be able to track them. But we expect that there'll be a number of patients who will be discharged from the military and who may not seek treatment at the VA, and they will be lost. And so what we plan to do for them is to send a follow-up survey after 2 years and ask them to provide some information. I'm not expecting that to be perfect because the response rate may not be optimal, but I can't really think of anything else to do to track them. We will also capture patients' mailing address too, so if the email piece doesn't work, we can follow up with them via regular mail. This is the group of core collaborators for the grant. Dr. Gregory Gum is the director of T2. Dr. Mark Rieger is the Deputy Director of T2, and Dr. Nancy Skopp and Nigel Bush are Research Psychologists and Program Managers at T2. Dr. Jan Kemp is the National Suicide Prevention Coordinator for the Department of Veterans Affairs. And Dr. Daphne Brown is our collaborator at Lungstuhl Regional Medical Center in Germany, which is one of the recruiting sites. Dr. Jennifer Hoblin is at Palo Alto VA. And we also have Dr. Kate Comtois on as a consultant. She's here at the University of Washington. And Dr. Gregory Carter, the carrying postcards guy, is a consultant on the project, and of course he's in Australia. So I want to make a couple of acknowledgments here. First, I want to give a thank you to the inpatient psychiatry staff at Madigan. They have been integral to making the pilot program work, and they will continue to be integral to making the RCT work. In particular, Miss Nurse Pierre, she is now the head nurse at Madigan Inpatient Unit. Colonel Knorr is the chief inpatient psychiatry. And Jennifer June, she's actually a T2 employee, and she's back there. She was the research assistant. She was the person with the boots on the ground, meeting with the patients, tracking the letters, and doing all the day-to-day operations. And also Dr. Julie Ken, she is a research psychologist at T2, and she was the program manager during the pilot study. So I'm going to open up to questions. I'm sure you've got some, and we've got plenty of time to talk about anything you want to ask about. Yes?
Are all the letters from San Francisco in English?
Excellent question. I don't know. I've read the original studies, and I don't recall any description of whether or not they were or not. That's a good question. I'm sure that when they were doing the interviews, they could have maybe notated whether or not English was primary or not, and then maybe sent letters in a different language. Or excluded, right. It's a good question. Yes, sir.
Suicide's a very sensitive topic for lots of different reasons. And I was thinking for soldiers, it could be an issue of their sense of confidentiality in relation to the service. And I'm wondering, are there factors along those lines that we have to take into consideration to try to deal with it?
Yes, there are. First off, we have an IRB-approved protocol. So, patients they provide their informed consent to be in the program, so they know what they're being involved in. And we do mention in there that they may, in the RCT, we're going to mention that they either may or may not receive letters or emails. So they know they're going to be contacted. And, they've already been in treatment, so they know that we know what they're in treatment for. And I think, in our focus group, we asked some of those types of questions, and the soldiers didn't seem to indicate any concern about that. But it is a good question. It is something that we're considering. Back here first.
This may not apply so much to the military, but the question comes up, if you were to do this in the private sector, would you be establishing a therapeutic relationship, an ongoing care relationship, by sending the letters that when somebody's discharged from the hospital, usually that's it. Your therapeutic relationship's kind of ended or somewhere near that period. This is dragging out for 2 years, 5 years, which may involve some medical legal risk. Is that an issue that was present or thought about? Or
we have thought about that, and I think this is research, so we're testing this intervention. And again, this is the only intervention that I'm aware of that's been published in an RCT type of study that has shown an effect on suicide mortalities. So I think we need to be paying attention to this intervention, and it needs to be replicated. So we're doing that. We're going to replicate it. We're going to see if it works, and if it does, then potentially this could be disseminated to hospitals throughout the Department of Defense and VA. I do know that the VA is doing a program that is similar to this, that they are doing a follow-up program with patients who are flagged high risk for suicide. So they are doing follow-up contacts, not for 2 years or 5 years. But it's an excellent question, and at this stage, it's research, and we'll see what we come up with. And they are doing some like I said before that, there's some studies that were done in other countries where they did follow-ups for a couple years, and they seem to be effective, but it's a good question. Yes, sir.
Thank you. Excellent ideas, very good presentation. Do you have any information on how many of the folks in the pilot study, of course, that the discharge remained in outpatient treatment for depression?
Good question. We have not, in our pilot study, tracked their outpatient treatment. We didn't really plan to do that. We do intend to do that in our RCT, you bet, because we think that's important, because we want to know which patients are continuing in treatment and how much treatment utilization that they are experiencing, and those who do not continue in any kind of treatment. I'll go over here first.
Yeah, just kind of along what you just said. Did you follow in your group at all, like, which ones were on psychotropic drugs and which ones stayed on them, or do you plan on doing that in the randomized controlled study?
We didn't specifically do that in the pilot study. We do have access to that information, but we can do that in the RCT, absolutely. That'd be another variable that we could consider in our models to at least control for or to examine. It's a good question. Yes, ma'am.
To control for substance use or for treatment, since there have been a lot of studies looking at the influence of treatment on suicidal behavior?
Yes, we will track the types of treatments that they're doing after discharge, and we can also control for types of diagnoses as well in our study design. So we will track that. Yes. Yes, ma'am.
Could you clarify in the beginning of the presentation, there was one slide where it showed, it was about the caring letters, and it showed that people who received caring letters and people who didn't. That was two of the variables, but there was also one that said treatment only, and their suicide rate was higher, their mortality rate, and
Yep.
I wasn't clear on what that meant.
Yes, when Motto's original study, they also examined the mortality rates of those who did not continue in any kind of aftercare after the index hospitalization, and they didn't send them letters or anything, but they tracked them anyways. And right, they had higher suicide rates. I don't know why, and I don't recall other than maybe some description of that maybe the patients were different, maybe they were again more severe diagnoses. Or some other types of variables. But it's a really important question, because in our RCT we need to be considering that, and these different subgroups, and what is it about who are going to be the responders to this treatment and who's not going to be. So we need to be thinking about that and looking at subgroups. Yes.
Question. You alluded to this, that there's a concern that maybe they were not getting emails. And my question is, there any way to get through that group, maybe as a first letter to ask them to respond to the first email to see, to confirm that you have indeed got prepared to risk? Because sometimes all of us have systems where a lot of stuff goes into junk email.
It's a very interesting idea. I think we thought about that, but we kind of wanted to stay along the lines of what Motto did and don't ask them for anything, But that might be something that's reasonable to ask for. Just let us know if that you received this. Want to make sure we got the address right. That may be appropriate. So we'll think about that. That's a good idea. Yes.
I've always, thinking about this intervention, I've always thought as that the impact of the letters kind of relied in part on people believing the letters are genuine, as opposed to part of a research study or
Yes.
part of something the hospital does for everyone.
Mm-hmm.
And so I was wondering, to what degree are you incorporating any kind of deception, or because it sounds like people, are you telling them they might get a letter, or that they may be getting these caring letters?
Yeah, excellent question. I spent a lot of time on that issue myself, thinking about it. What happens when we consent people? We should disclose to them what we're going to do, right? And will they believe that this is real or not? And we do consent patients. They do know that they're going to receive follow-up contacts. I don't believe we say how long, but we do say that they'll receive letters. And I wish I had brought in some example letters that we had received back, but I'll tell you, I read these, and that's where I know that caring letters are effective. I read these letters back, and they're like, "Thank you so much for sending this letter or for contacting me." And they'll often tell a little bit about their story, about what's happened to them after discharge. And that's where I know that, okay, these letters are powerful. And I don't know if they're going to prevent suicide yet or not, but I do know that they mean something to those who are receiving them, at least the people who send them back to us. But it is an ethical concern too. I do believe we should tell them that we're going to be sending them letters, and they should understand why. But you're right. Demand characteristics will affect.
So they do know the purpose of the letters then?
They know that, right. They do know that they know the name of the project and what it is. It's basically a standard consent form. Yes, Jen.
Just with you, in the interview at the end, I do specifically say, is it okay if I send you an occasional letter? And so that's when we indicate whether to say yes or no, and everyone that I've interviewed so far has said, yes, please do. Yeah. So, and like just recently we had an individual that thanked us for wishing him. So things like that, we do take care and take care of the kind of details that we're giving there. Whatever, that's just part of that personalization.
Yep. Yes, ma'am.
So is there concern then, particularly for these patients that really seem to depend on these letters, that after 2 to 5 years they were also stopping letters, that they might have, greater than expected rate of suicide or something that?
Yep, excellent question. We've thought about that too. In fact, we're continuing to send letters because we just finished our pilot program, but we had people enrolled up until maybe a month or so ago. So we'll continue to send letters to those patients. We do in our RCT, we describe that we're sending, we let them know that we're going to be sending them one last letter. So they know that the last letter is coming. But we can't send them forever. So we kind of have to do that. We have to have some cut point. But it does raise that question, what does it mean to them when they're not receiving it anymore? If that was like a lifeline to them or something. But there's a kind of the balance of what's feasible and what's the ethical piece of it too. And so we're going to do it for 2 years. I'll go back to you back there first, ma'am.
What percentage of the people that you're sending letters to respond or establish a file?
We've had, I think, about close to 20% who have responded to our contacts in the pilot program, which is basically the same that Mata had found in his study. So, which was kind of neat. We didn't know what to expect, and we spent a lot of time thinking about the email thing. In the culture of email, it's a very quick response. You don't have to spend time writing a letter and going to the post office. It's very quick. So we were concerned that maybe, if a patient sent an email back to us and we didn't respond for a couple of days, that, is this a real problem for us? So we included in our emails a statement that said, basically, we make an attempt to check our email every day, but maybe not every day, kind of thing. So we'll get, just so that they know that not to expect an immediate response from us when they send it. And our protocol calls for us to check those daily. So.
Thank you.
Sure. Yes, ma'am.
A couple of years ago, I worked on a study where we did get feedback from people, and we saw that we had sent them through mail, and it was really interesting to look at their responses, their language in response to our letters to them. And it served as a pretty strong indicator of the emotion of them. So I was just wondering if you had looked at maybe either qualitatively or linguistically their responses that you get back, and kind of to look and see if there are any mechanisms to engage.
Yes. Again, that's like another one of the subgroups that we're definitely going to want to look at. Those who respond back to us. We'll look at their characteristics, maybe their diagnoses.
I also mean just the language.
Okay.
It impressed me how you said they really responded warmly and they were
Right.
excited to get the letters, and it feels like that emotional response that they're giving to you, maybe you could analyze their language around that and sort of what they're giving you. So when you say, oh yeah, they really responded well to this, but maybe you can quantify that or present some qualitative comments on that so we understand how to feel.
That's a very interesting idea. I hadn't really thought of that before. That might be an interesting study to do on the content of letters. Yes, sir.
I'm curious what proportion of people consent to participate, and if there are any characteristics that predict somebody not participating in relation to their risks.
Good question. In our pilot program, we intended to enroll everyone that we could, that we had time to meet with up on the unit. And so that's what we did. There were a couple issues. One was sometimes we would miss patients. They'd be up on the unit. They would come in on the weekend. We weren't there, so we couldn't enroll them. They're discharged first thing Monday or something. We missed them. So we had patients like that we just missed. And I can't recall the percent that actually declined participation. Do you remember, Jen? It was pretty low. It was a very low percent. Was it that much? Okay.
That ran the gamut. I mean, some people just did not have postal or email. Some were from on the streets that were abandoned. So some veterans who they were not able to participate for that reason, or just really concerned about their personal information, things like that. So,
Right. So, but that's an interesting question because there will be a subgroup that won't want to participate, and it does call for that question. What is it about those people? It's an interesting question. Any other questions? Yes.
Can you clarify when you were saying that you respond to their emails? So when you email them and they email back, you're going to respond to them. Does that ever get caught up in the conversation?
Yeah, we were concerned about that because we might have a patient that is doing that and wants the constant dialogue, and so we kind of, I say this lightly, we've had our fingers crossed that wouldn't happen, but it could happen, right? So our procedure is that we try to follow our set schedule of sending emails and letters. So we try to maintain that schedule. If a patient does, again, if they do indicate a crisis, we follow our protocol and notify the inpatient right away so they handle it. I don't recall, did we have any cases where we had to send something back out of schedule? Do you recall? I don't think we did. So we were able to follow our schedule all along, but it's possible that could happen.
It is personalized. I mean, somebody gives us a response, and they're like, "Thank you so much for your response. It's great to hear from you. It's good to hear that patient is along the way." They respond to their last response.
Yes. So in other words, we're acknowledging that they're communicating to us when we send the next letter. Any other questions? Yes.
How is it determined which those people are at, say, Madigan Army Hospital, and which are certain
Well, you mean as far as for the big study that we're going to do, or?
Well, just in terms of, I would assume that discharged service people will be served through the VA, and if they're at Madigan, they're current military. Is that correct?
Right. There is a lot of variance in what happens to patients after the discharge. They may stay in military service for some time. If they're discharged, they leave the military, they may or may not seek care at the VA. In our big multi-site study, we'll be able to track that, and so we'll know if they're continuing care or not. But I think that's what's so beautiful about this intervention is that it targets those that don't continue in care, who are otherwise lost to treatment. And so that's, to me, is what is really special about this intervention. Yes?
Just to clarify your response to this woman's question about informed consent, it wasn't clear to me whether or not the patient or the enrollees are being told that they're going to be receiving letters or not, and that we're looking at rates of suicide down the road, several years down the road. Are they actually being told that piece?
I don't think in our consent form it mentions the suicide piece per se. We do mention.
It seemed to be an important point in the study, looking at the psychological effect of being told you're getting these letters to help prevent suicide versus being told you're getting these letters because we care about you.
Right.
And those two things could be both true,
right,
but how the enrollees are perceiving that.
We actually don't say either of those in the consent. We don't say we're just sending them because we want to show that we care about you. We just tell them that we're going to be sending contacts or following up with them, but also looking at their some treatment records and things. So they know that we're looking at their information. They know that, and they know that they're in a study. But it's really that line of kind of an ethical thing. It's like in the demand characteristics. If you tell them that we're doing it just for this reason, maybe they're going to react to it differently then. So And so we leave that burden on the IRB to help us figure that out. And so when we do work on our protocols for the big RCT, we'll work through those issues. It's an excellent question, and something I know I spent a lot of time thinking about that. Yes?
I'm wondering, you have a control group that doesn't get any letters, so how are they informed of the consent? How does that
Yep.
factor?
For our pilot study, we didn't have a control group, so everyone that we enrolled received letters because we just wanted to examine the feasibility of doing it. But in the big study, the RCT, we will have a control group that will not receive letters. We will enroll them in the same way. They will have the interview just as we did with the group that received the letters, so we will do, and they will consent and everything. And so we'll say they may or may not receive follow-up contacts from us in the consent. And so they will be treated the same and be randomized, and also the person doing the interviewing will be blind to that. They won't know which group they're going into, and they won't even know. Yep. And one last thing, this is my contact information. You're certainly welcome to contact me if you'd like more information. And I added our website there on the bottom. If you'd like to learn more about T2, you can visit our website. And yep. And I understand that there could be some online questions. And Dr. Veith is asking which VA medical centers will be involved. We have the Palo Alto VA on board in California, and I am working with, I'm actually going to be talking with a VA in New York State on Monday about possibly participating in the study, which would be great. So right now we're looking at 2. If I could identify a couple others, that would be great. So if Dr. Veith knows anybody, let me know. Yes, sir.
We had a speaker a number of months ago from Australia who talked about their program, and my memory was that they had fewer letters. Is that do you know that study? They had fewer letters that went out and had a very positive response with, I think, postcards.
Yeah.
Just signed by the attending. And
Gregory Carter.
No personalization,
Yes.
no nothing.
Yes. In fact, he's a consultant on our project, and problem with that study, it wasn't a problem, but they just didn't have enough participants to look at mortality rates. So we're going big, and we're going to examine mortality rates. Okay. Thank you very much for coming.